ധനിഷാറ് ഒന്നല്ല ധനീഷ്
ജോയിൻ ചെയ്തിട്ടുണ്ടല്ലേ?
നമസ്കാരമുണ്ട്.
സാറേ
ആ അതെ, താടിയൊക്കെ വെച്ച
കുറച്ച് വേരിയേഷൻ ഉണ്ടല്ലേ?
ആ
സുഖമാണോ?
സുഖം സുഖം.
എന്ത് പറ്റി പെട്ടെന്ന് എന്തോ മീറ്റിംഗ് വന്നെന്ന് പറഞ്ഞേ?
നമുക്ക് ഇടയ്ക്കിടയ്ക്ക് എപ്പോഴും ഈ മീറ്റിംഗ് ഉണ്ടാവും. നേരത്തെ ഒന്നും പറയില്ല, ജസ്റ്റ് പെട്ടെന്ന് വിളിക്കണാണ്. പിന്നെ എപ്പോ തീരുമെന്ന് പറയാൻ പറ്റൂല. പക്ഷെ അത് കഴിഞ്ഞു. കാരണം അത് കഴിഞ്ഞ് വേറൊരു മീറ്റിംഗ് വന്ന് ടീമിനൊക്കെ, അപ്പം അവര് നിർത്തിയിട്ട് പോയി.
ഓക്കെ.
ഈ ഫാം ഡി ഫസ്റ്റ് ഗ്രൂപ്പ് എപ്പോഴാ ഗ്രാജുവേറ്റ് ചെയ്യണേ? അത്
കഴിഞ്ഞു.
കഴിഞ്ഞു.
പക്ഷെ ബാക്കി ഇപ്പൊ എക്സാം അല്ല, ബാക്കിയുള്ള ഫോർമാലിറ്റീസ് ഒന്നും തീർന്നിട്ടില്ല. ഇന്റേൺഷിപ്പ് ഒക്കെ കഴിഞ്ഞു. ഇപ്പൊ ഈ മാസം അല്ലെങ്കിൽ നെക്സ്റ്റ് മന്ത് ഒക്കെ ആയിട്ട് പാസ് ഔട്ട് ആവുന്ന പറഞ്ഞേ.
ഇന്റേൺഷിപ്പിന് വേണ്ടിട്ട് നിർമ്മല ഹോസ്പിറ്റൽ അല്ലാതെ വേറെ പല ഹോസ്പിറ്റലൊക്കെ പോയായിരുന്നോ?
രാജഗിരിണ്ടായിരുന്നു, ആസ്റ്ററുണ്ട്, പിന്നെ കാരിത്താസ് ഉണ്ട്. അങ്ങനെ കുറച്ച് പല സ്ഥലങ്ങളിലായിട്ട് ഫ്രണ്ട്സ് പോയിട്ടുണ്ടായിരുന്നു. നമ്മുടെ ഇപ്സോറൊക്കെ ഇപ്പോഴും നന്നായിട്ട് ആക്റ്റീവായിട്ട് പോകുന്നുണ്ട് സാർ.
ആണല്ലേ? കൊള്ളാം. നല്ല കാര്യമാണ്.
സാറ് തുടങ്ങി വെച്ചതാണല്ലോ.
അതെ, പക്ഷേ നല്ലൊരു ഏജൻസിയാ അത്. ഒരു ഇന്റർനാഷണൽ ഏജൻസിയാണ്. പിന്നെ കേരളത്തിലെ ഒരു കോളേജും കൂടി തുടങ്ങിയിട്ടുണ്ടെന്ന് തോന്നുന്നു. ഞാൻ ഇടയ്ക്ക് നോക്കിയപ്പോ കണ്ടിരുന്നു. അൽഷിഫയില്.
അൽഷിഫ വേറെ കോളേജ് ഉണ്ടോ എന്ന് എനിക്ക് അറിയില്ല. ഫാർമസി പ്രാക്ടീസ് ഡിപ്പാർട്ട്മെന്റ് ആണ് അതിപ്പം.
അത് ഈ ഫാർമക്കോഎക്കണോമിക്സ് തന്നെ, ഔട്ട്കംസ് റിസർച്ച് ഇത് തന്നെ സ്പോറ്.
അൻസി മാഡം, ഹലോ അൻസി മാം.
Sir, can we start?
Okay. Okay. So
Hello.
I'm starting, right?
Okay. Hello, good afternoon, everyone. Welcome to the second session of fifth day of our international conference. I am happy to introduce respected Dixon sir and invite him to deliver his ideas. United Arab Emirates. He practices as drug information pharmacist and director of the Center for Drug Information and Evidence-Based Pharmacy at Tumbe University Hospital. He started his work with Gulf Medical University as an assistant professor of pharmacy practice in November 2014. In addition to the above mentioned responsibilities, he is the chair of Quality Assurance and Program Evaluation Committee. He had a diploma, bachelor's, master's, and PhD degrees in pharmacy, master's degrees in education, psychology, and currently he is pursuing an MBA. He is widely regarded as an expert of clinical pharmacy practice, quality in pharmacy education, drug information, and evidence-based practice. Special mentions are successfully completed Ministry of Education accreditation of pharmacy program and its international program certification of PharmD by Accreditation Council for Pharmacy Education, USA. Foundation of the Masters in Clinical Pharmacy program and revision of PharmD curriculum at Gulf Medical University. Published an Elsevier book with 83 contributors from 25 countries titled Clinical Pharmacy Education, Practice and Research. Consultancy services in pharmacoeconomics and outcomes research and pharmacy education. Establishment of a Center for Drug Information and Evidence-Based practice at Tumbe University Hospital. We are so happy to have you here for today's session, sir. Over to you, sir.
Okay, thank you very much, Ansi ma'am. So if all participants mute, we can start the session. Thank you for this nice introduction. Okay, so everyone please mute. I'll quickly go through some important concepts in an application point of view. Yeah, I think someone is still not mute. Yeah? Kindly mute.
Sir, could you please unmute yourself?
Yeah, thank you for muting. Good. So I'm going to start. It's about pharmacoeconomics and outcomes research. I know those who are in PharmD did this course. So we'll quickly go through some important concepts. Yeah, so always, in healthcare, there is a problem, or in anything. This is the basic fundamental principle of economics, that people are having unlimited wants. We are never satisfied. We want more and more, but the resources are limited. So this causes scarcity, as resources are limited, but people want more. We need more treatment, more better drugs, more better surgery, more safer treatment. But the resources are limited. They are costly. They cannot give it subsidized. We know government is giving subsidized for only essential medicines. The other medicines, they are not able to give it free. For example, last year I was invited to Saudi for giving this talk. So there, most of the treatment, not all, most of the treatment is given free for everyone by the government. But why they cannot give all treatment free? It will consume lots of budget. So resources are limited even for any rich country in the world, any rich family. Resources are still limited. There is nothing called as unlimited resources. So always there is scarcity. We have to choose between what to produce, how to produce. So this is an industrial perspective to decide on what to produce, what is having a market, which is acceptable, which is affordable for people. Only if it is affordable for people or society or even the government, they will purchase. So there is a fundamental issue of, even if it is extremely good, even if it is a lifesaver medicine, there is a problem of affordability. Can people afford it? Can people buy it? So this creates the problem and opportunity for pharmacists and other healthcare professionals, so that they need our services and products. And always, as you know, in basics economics, there is a balance between supply and demand. Oversupply causes surplus, less supply results in shortage. So less supply, demand increases. You might have studied this before. It's a fundamental principle. And basically understanding few differences between terms like, efficacy, effectiveness, efficiency, and affordability. These are fundamental concepts in pharmacoeconomics and outcomes research. So efficiency is about, when we spend less, we get more, or we get same. When we spend less, that is an efficient process. Then efficacy is what we see in clinical trials, not in real world setting. It's an experimental made up situation where extra care is provided, the diet adherence, everything is perfect. In that condition, we see optimal results from medicines. That is efficacy. We may not see that optimal result in the real practice, real world, where people have trouble in buying medicines. Even if they have medicines at their home, adherence may be limited because they forget There are some adverse events. There is no nursing care available at home. All these effects, and what we get finally is an outcome which is not optimum. Okay, that is effectiveness. That is real world. What is really happening? So we have to differentiate, just like, when you purchase a vehicle, a car, there is a showroom performance and on-road performance. On-road performance is less than what is in the showroom condition. Yeah. So this applies, and we have to be considering this situation when we look at what is the outcome from the medicines. So health technology assessment is a broader term widely used in pharmaceutical industry, and the governments look at it. So any medicines are reviewed for its cost effectiveness and budget impact. Cost effectiveness means value, worth for paying. There is value. The medicine is good. It's doing good for human being. Health improves. Disease is controlled. But what is its impact on budget is another thing. That is affordability. So if it is not affordable, even the best we cannot buy. So again, from my book on clinical pharmacy education, practice, and research, there are many sections about, at least 5 chapters are there on pharmacoeconomics and outcomes research, and other chapters are there on clinical pharmacy. So overall, as you know, quality of medicines, pharmacists are always building all the learning on these qualities of medicines. One is effectiveness. The medicine should work. Then safety, it should not kill people. The medicine should be safe. And the product should be of good quality. Substandard quality product is not acceptable. Fake or counterfeit product is not acceptable. And then even if it is very effective, very safe, and high quality, high pure product, if it is not affordable to people, they cannot purchase or they cannot access even through their insurance. If it is too much expensive, the insurance company will not pay for it. So all these are qualities of medicines. This should be kept in mind while designing, while discovering or developing a product. This should be kept in mind. Otherwise, the pharmaceutical company make a very good product, very high quality, very safety profile, very good safety profile. But once it is coming to market, if it is not affordable to people, they will not get sales. So, they will encounter loss. The business is for profit, and they need to get profit for survival and further research. Income should be generated. So this is in regard to the development of medicines and new technology. Medicines can be said as new technology, medicines and devices. So there is microeconomics and macroeconomics. You might have seen this picture. It's from DPRO textbook. Macro is a national level or international level in a big picture. Micro level is to a particular patient or a particular institution, particular hospital. Just that, if you are appointed as a chief pharmacist in a hospital, then you have to look for what formulary management and other systems in place, the drug budget in the hospital. All this can be controlled. That is microeconomics, just for one institution. Yeah. So economics is a broader science. Health economics is part of that, and pharmacoeconomics is again a branch of health economics. They say, in money-wise, pharmacoeconomics is just 10% of health economics, but volume-wise, we know that it is at least 70-80% of healthcare. Money-wise, why it is less? Because most of the money in health economics is spent for the infrastructure, building new hospitals, buying MRI machine, such costly machines, surgery set up in a hospital, and surgery costs more. So relatively, the medicines cost is just 10%. That is good news for us, but most of all patients are in need of medicine. So in volume, we are number one. Both ways, it's actually a good situation for pharmacists. When we look at the outcomes, there is economic outcome, clinical outcome, and humanistic outcomes. A combination of that works well because we have to be considering patient satisfaction, that is humanistic, economic outcome, good for the patient if patient is paying out of pocket, or for the employer or the insurance company or the government if they are the payer for healthcare. Clinical, of course, is interesting to us as we are clinical healthcare providers. We look for always the best outcome for the patient. So harm may happen if the drug is not given, the disease causes harm, or if wrong drug is given or overdose is given, that also causes harm to the patient. So pharmacists should be there for the optimal use of medicines so that there is no underuse or overuse of medicines. So it's all part of outcomes research, and some says outcome science. Some of the departments in US, they change from pharmacy practice department to pharmacoeconomics and outcomes science, or pharmacotherapy and outcome science department. So, outcome science is becoming, or outcomes research is becoming a major sector for pharmacists and replacing the traditional drug utilization research. So cost and consequences are compared. This is the essence of pharmacoeconomics. When we have more than one option and cost is different and the consequence or the outcome is different, then we have to choose. We have to choose wisely. It is not always the cheaper drug is the best. Cheaper drug is causing more adverse events, then overall cost is not decreasing, overall cost is increasing. All these adverse events to be treated, all this end organ damage to be treated, death, increased hospitalization, all this adds cost. So sometimes when we go for cheap one, it's not actually saving our budget. It actually results in more spending, right? So this is why pharmacoeconomics is important in those situations, and the cost, how we measure cost is important. There is direct medical, direct non-medical cost, and indirect cost, intangible cost. Intangible is something difficult to measure, like pain, suffering, and opportunity cost. Okay, so this is basic, you might know it. And one exercise is given because traditionally I do this as a workshop. So the participants do an activity like, vaccine, right? All medicines, lab test, doctor consultation, all these are direct medical cost or fine. So again, we can see pain, suffering, all these are intangible costs. This is important to be considered. We know that, inconveniences are bad. If patient is unsatisfied with the care, maybe we offer sometimes if the customer is unhappy, we offer, or next time your consultation fee is 50%, or they are given a free coffee coupon. Okay, there is coffee shop in the hospital, so they can, like, people are waiting and their time is precious, so that need to be respected. You see that in airlines industry a lot. When the flight is delayed, the airline company is giving okay, airline company is giving some coupons, food coupons, to satisfy the patient. This is humanistic outcome. Okay, humanistic outcome means people should be happy. Patients should be satisfied with the care. This is extremely important. And nowadays, hospitals in India also is putting a stress on that to achieve best customer feedback, the patient feedback. That is important for the business, and also it's having a value, it's having importance. The patient cannot be a quiet person all the time. Person should be happy. The patient should be happy. Patient should have a voice. If they are unhappy, the treatment should change. Okay, that means they are having a voice. Otherwise, patient used to be a silent partner in healthcare. That is not. That is opposite of patient-centered practice. In patient-centered practice, patient is having importance. Their voice is important. It need to be heard and acted upon, right? So there is again some activity. We will skip the activity as it is not very interactive session and time is limited. We will not do the calculation activities here. Just for an example of opportunity cost and budgetary cost, if you want to see a difference, there is an example of a local influenza vaccination or polio vaccination project. In that project, few nurses are required. For example, 4 nurses are required, and we appointed only 3 nurses, but those 3 nurses will do the job with help of a volunteer. Then volunteer is not paid. Actual expense is only 900 for the nurse, but we have to consider in the correct situation, the expenses or salary of 4 nurses should be counted, okay? Because that is the optimal situation. So that is the difference between opportunity cost and marginal cost. Again, when pharmaceutical company is making a new medicine, for the first unit to be made, it's very expensive. All set up, new machines, new process validation, everything to be done. But, once certain number of products are made, making additional products are not very expensive, okay? Additional, because everything is set, the machine is running. So additional products are made with marginal cost, very less cost. Incremental cost is the difference between two different options, what we compare, okay? Then again, in pharmacoeconomics, we actually compare the consequence, effectiveness, benefit, utility. These are different type of pharmacoeconomic evaluations. And what we look for is humanistic outcome, economic outcome, and clinical outcome. We'll see one by one. With treatment, there is a positive outcome and negative outcome. Positive outcome is cure rate. People are leaving the hospital, living for more extra years. That is positive outcome. Negative outcome is treatment failure. Still symptoms are continuing. Adverse events are happening. People are dying. Those are negative outcome. And then intermediate outcome and final outcome. Okay. So control of LDL cholesterol is an intermediate outcome that is having a good prediction towards in future if we avoid myocardial infarction or other thromboembolic events. It cannot be 100% correlated, but there is good correlation. Bone mineral density is an intermediate outcome. Then there is a possibility that if bone mineral density is less now, then this may lead to future bone fracture. But every time it may not happen. So it is not as strong predictor, but still a good predictor. Right. Smoking causes cancer. Can it be a strong predictor for the final outcome? Not so much. Okay. So this is why final outcome is what is most important, but we cannot wait until the final devastating outcome is happening. That's why it's a very good, useful technique to monitor interim outcomes so that the final outcome can be prevented or delayed. Patient perspective is important. provider perspective, payer perspective, societal perspective. Okay, in healthcare nowadays, what is becoming more important, more research is done on payer perspective. Insurance companies are payer mostly here, but in India might be the patient perspective is the most prevailing one, as most of the patients are paying out of pocket. Okay, so societal perspective is difficult because everyone's perspective put together in a study or in practice is really difficult. But perspective to be considered, it need to be mentioned in whatever project or research what we are doing. This is a compilation table of who is concerned. Government is interested in societal perspective. It needs to see all parties in the country are happy. Yeah. Then how we implement in pharmacotherapy in patient care, this pharmacoeconomics data, we can just take it from the literature and use it, okay? Or otherwise, some gap is there in the published literature, then we have to create a model. Economic models are used mostly by the pharmaceutical companies because building these models are resourceful and companies can afford it. They do that a lot. There are many professionals taking pharmacoeconomics and outcomes research as their primary career. They do masters and PhD in that area, and such people are in demand for the pharmaceutical companies because, again, whatever new technology or medicines they are developing, it needs to be cost effective and affordable as per budget impact. These studies they have to do and convince the governments so that the medicines are getting a good entry to the market, and also the government will pay for it. Otherwise, if government in Saudi Arabia, if government is saying, what is new product, we are not going to pay for it, then they cannot reach patients because the government is the main provider there, main payer there. UK, same situation, because the drug needs to be in NHS formulary list, because most of the patients are provided treatment with the NHS facilities. Even pharmacies are part of NHS. So it's a national fund. If the newer medicines what are developed by the pharmaceutical companies, if it is not getting into the formulary of the government or each individual hospital, because more and more hospitals are being managed by formulary. So if it is not happening, if it is not entering in that way, because the model of marketing is changing, it's no more the doctor, more powerful person in the medicines business. So it needs to go through the formulary inclusion. If once it is in the formulary, then doctors will prescribe. Okay. So that's why, again, pharmaceutical companies, when they make new medicines or existing medicines, they always look for how to make it more looking nice, appealing in pharmacoeconomics and outcomes point of view. And if these two are not feasible, then go for the tedious, expensive method, that is pharmacoeconomic study needs to be done. That is not feasible. Keep doing so many studies. Basic understanding is that when you look at this basic decision tree model, this is a model. This is a simple one. People can do it even manually. Comparing two treatment options, when you simply look at it, drug A is only $60, but drug B is one second. Yeah. Okay. So the drug A is $60, but drug B is $90. So it looks like $60 drug is cheaper and better? No, because it causes more adverse events. So the overall cost is actually higher for the drug A group. You can see that Acer 385, because the cost of adverse event also to be included. Ultimately, the government is paying for it. And then here, even though the drug is costly, individual drug is costly, the other expenses, the number of hospital days, new hospital admission expenses, those expenses are less here. So overall expense is 369, which is lesser than treatment option B, option A. Okay. So that is the ultimate point. Even if we spend a little extra for the medicine, if it is preventing hospitalization, if it is preventing a surgery, you might remember earlier, many patients with peptic ulcer used to undergo a surgery for healing peptic ulcer, for fixing peptic ulcer. Nowadays, not. Proton pump inhibitors with the regimen for H. pylori eradication is especially credit to be given for proton pump inhibitors. Once it came, that combination regimen is very effective to immediately resolve symptoms and help in healing. Yeah? The healing happens for the peptic ulcer. So surgery is not required. So in that case, if proton pump inhibitor is costlier than famotidine, still overall expenses are less because less surgeries are done. If surgery is done, the overall expense is more. So very rare now any people with peptic ulcer undergo a surgery unless a perforation happens and the situation is really emergency. Markov model is complicated. Without software support, it's difficult to do. So hopefully you could have studied different type of pharmacoeconomic evaluations. I'm not going through in detail as it takes time. This table is given here. All these cost benefit, cost effectiveness, cost utility, and cost consequences analysis are full pharmacoeconomic evaluation because the cost is different and the consequence or outcome is also different. In that case, we are confused. Okay, there is more money to be paid and also there is more benefit. How much more benefit is the next question. If it is significantly higher benefit for the extra money what we pay, then we can say, oh, it's worth paying for that extra benefit. This money is worth paying for it. That is the situation you can see in the middle. Otherwise, if this new treatment is better than older treatment and it's cheaper, then why to think? Just accept it. Now we are getting something better than the existing treatment for a lesser money. That is easy accept. We don't have to do any calculation. If the new product is more costly and giving more bad outcome, so who will pay for something bad than what is existing? Who will pay extra money for that? No one. No need to calculate. That's a reject. In between is the doubt. That is why we do pharmacoeconomic evaluation to see, is it worth paying this extra money for this extra benefit? So ICER is calculated to see what is the incremental, what is the difference in the cost compared to the effect or outcome. Then, based on that, what additional cost we pay for additional benefit, we decide. Still, we cannot pay 100 million for one additional benefit. Of course, basically, we don't have that money. Okay, even if it is a good thing, So this is why we focus on new treatments which are more costly, that is the usual situation, and more effective. But there is a threshold. More than certain amount we cannot pay because we don't have it. We will bankrupt. The country cannot spend on other infrastructure to build building and structure, defense, the education. All this money will go in healthcare if they don't keep a ceiling, So UK usually they used to do 20,000 to 30,000 pounds. This is old one, 10-year-old. Now they are paying more, but still they try to keep a ceiling, keep a limit. Okay, so when it goes to US, you can consider something like 50,000 that time, 10 years back, but now that is definitely higher. And USA nowadays they are not looking at the fixed amount per collie. So that's why low molecular weight heparins are better than warfarin, especially in home care. Home care, some bleeding happens, no one is there to take care. But if the patient is in hospital, then warfarin is okay because nurse is there and routinely INR is checked. So any possibility of bleeding is found well in advance and they adjust the dose. So in institutionalize the patients, warfarin is still a good option. Why to spend more for enoxaparin? But home care patients, it's a good idea because if patient is ending up with a bleeding and some devastating thing happens, stroke happens, that costs more than what we spend for the medicine. That's why overall, if for one additional benefit, if it is even over $100,000, it's acceptable. Yeah, people pay, especially in the US because for them it is more affordable. Overall expenses are higher in the US because if you consider a Pfizer product, the same brand, same product, same quantity, sold in US, and that in dollars only, when we see the price in Europe is 3 times lesser. And maybe in India, same company, same product, same brand, same strength, same quality, in dollars, it will be maybe 10 times cheaper. Okay, because the purchase power of people in India is less. So they cannot sell for a similar price what is in the US. US price is crazy high. Yeah. So again, utility is compared, is measured by using standard gamble or time trade-off. This is actually a tricky situation where to understand how much they are suffering, if a person is having a mild problem, okay, no, leg is paining, still I can manage, there is no big deal, but a surgery to be done. Now the surgeon says, okay, if you undergo this surgery, there is a 30% chance that immediately you are going to die. 70% chance that you will be perfectly all right after the surgery. Do you think patients will accept it? No, because it's just a small pain and they don't want to be like, one of the 3 in 10 patients who are going to die for a simple benefit. So this response shows how much they are suffering. Maybe another person not able to walk, not able to take care of the person is feeling like, oh, better if I die, that is better. I'm suffering so much. That person will say, there's 70% of chance I'm going to be fully healthy. Let's go for it. 30% is okay. Even if it is 50%, 50-50 chance of dying immediately or becoming fully healthy, I want to take that chance because I feel like I'm already dead. I'm of no use. This shows how much they are suffering. That shows in their perception their utility of health. Okay, this is how we measure. I'm not going too much in detail. This is how we measure the utility. And again, from the hospital budget, in the UK, NICE is the agency which is doing health technology assessment and decide which medicines to be included in the NHS formulary. So there, right, it's important. They cannot open their doors to any new good drug, because many pharmaceutical companies make many new good drugs. If you open including all those drugs, they will run out of their budget. Their budget is fixed. So what they do, okay, if this new drug is extremely good, we are not blindly including into our formulary. What we do, we are ranking based on the QALY and cost per QALY or cost per utility benefit. We are ranking the products which is already there in the formulary list. So if it is so good, it will come into the formulary, but some existing drugs from the bottom, which is not giving so good for our people. Okay, not even if those drugs are not there, still people are going to be fine. Such drugs in the bottom of the list will be thrown out. Okay, so there is no new money, no extra money, no new money to accept new medicines. With the same money, we will manage by removing some drugs which are not doing so good and accepting new drugs. So it's a competition. The space is limited, okay, and only the best medicines can enter, right? So this is a big challenge for the pharmaceutical companies to look for giving maximum benefit for the drug. And also, there is a new system now called pay for performance. This means the government will say, okay, if you're so confident your drug is the best, we will accept it. We will start giving it to the patients only if we see the benefit as you say in your studies, because your studies are efficacy, that is in experimental setting. In our patient, in real practice, if you see that effectiveness, this is the difference I said between efficacy and effectiveness. If we see that effectiveness and our people are improving, their health is improving, they are going back to job, more healthy people will work more and contribute to the national money. So the government is paying, that money is coming back from its healthy people, productive people. GDP is going to increase. Okay, so government is not doing charity. Government is doing business. Government is investing on its people to make them more healthier so that they pay back to the government through tax and other resources. Blindly, we are not seeing how much money government gets from people. Many ways government is benefited, so it is people's money. Okay, even in UK, US, all this money in the budget is from people. So the government will say, the pharmaceutical company, we will pay only if we see our people are improving in their health, their life is saved, then we will pay. Okay, pay for performance. If the medicine is not giving the expected outcome, we are not going to pay you. Okay, no, you get no money for your medicine. What we use, we are using your medicine, but you get nothing if the medicine is not working. Okay, fine. So many interesting developments are happening in pharmacoeconomics and outcomes research. So there are many tools like this also. This incremental net benefit in cost to benefit analysis is very compelling to the decision makers, because many decision makers, many ministers are not from the healthcare background. They don't have any degree from healthcare. They don't know what is healthcare. So in that situation, but they know money. So here, what happens is like, monetizing the benefit also. Cost is in money, and the benefit is also in money. In that situation, anyone can see where is more money. Okay, cost side more money, that is bad. Benefit side more money, this is good. Even a child can take a decision. Okay, but it's sometimes unethical to say price for the benefit, price for life. If a life is saved, how much money we assign for it? If kidney saved, how much money for the kidney? It's tricky, but we do that. There are many methods to do that. So the benefit and the cost, what is the difference, and also ratio can be taken. Fine. Why it makes sense is, or governments or people about healthcare should take a decision. Ultimately, if I'm going to a hospital, they say for your condition, there are 3 different types of surgery. The outcome is different, cost is also different. Surgeon explains to me, then I should finally take a decision. I go with this surgery, not the other 2 surgery, right? The government should also go with such decisions. Now, in India, HIV medicines are given free of cost. People need not pay. It's free. TB medicines are given free. Why? Because it's not just if it is left to the people, government is going to lose more money. More people are affected. More people are dying. More people are morbid. They are not working. What happens? The national income from work decreases a lot. Yeah. Now, just with COVID, how much is the loss? It's not just the money loss from the hospital. All other related industries are affected. Airlines industries in loss, hotel industries in loss. So the estimated money loss or money benefit is going to be many times than what is spent in healthcare. So what is advisable is to spend more money in healthcare than just the infrastructure and defense. All those money is good, but you know in India, I feel like the overall healthcare budget, the money spent for healthcare is less than 5%. Even in UAE, it was 4% last year, and then it's going to be a little bit higher. US is the one spending too much. Nearly 20% of their whole income is spent on healthcare, but still, US healthcare system is not doing so good. UK is better. They are spending half, nearly 8-9% of their GDP is spent on healthcare. So it's a wise idea. Identify the areas where it's affecting the whole country's health and well-being, happiness of people, healthy situations. It's not just money, okay? More than that. Whatever money spent is coming back. Thank you. This is the whole idea. Hopefully, I gave some additional perspectives and examples for more clarity in this sector and way forward, so you can take decisions, more better understanding. Because what I should say, we have in Nirmala College is 4 chapter, because I think it was 2010 I started reading or happened to know about pharmacoeconomics and outcomes research, and it was not in our curriculum before. It is relatively a new science. So immediately after I started learning health economics or pharmacoeconomics and outcomes research, because they are very close to each other, my way of thinking changed, my way of writing changed, my way of patient care changed, because it gives a comprehensive viewpoint about how effective, how safe, uh, how affordable these medicines are, and our recommendations are. And in a holistic viewpoint, I can see who all benefit from it, not just the patient, even the society, the government is getting benefit. So, lots of improvement happened to me because of studying, not formally, just by interest, the pharmacoeconomics and outcomes research. So in our university, they started a new college, healthcare management and economics. I was invited to develop their bachelor program and master program. So I was in core team to develop those programs, and I teach in programs. This is a big major field, and it is close to industry as well as practice. Okay, this is kind of like, what is important for all, it's dealing with money and outcomes. So it's important for all sectors in health. Yeah. So hopefully you will have more benefit from this field of science. Thank you then. Thank you, Ansi ma'am, for introducing me. And if any questions are there, happy to answer now.
Thank you, Dixon sir, for the informative session on pharmacoeconomics and outcomes research. Now the session is open for discussion for the participants. Participants can ask their doubts regarding the session.
Sir, like it is heard that in your place, that is in Gulf countries, the same medicines which we get here are very expensive compared to the price in India. I hope it is true.
Yeah, the simple example is like, just a tea or coffee, there in India, what is the cost, and here, what is the cost is different, just like that. But, you have to consider also in India, the same care, because medicine cost, they cannot change much because it's controlled by the government. Government is fixing the price. So it cannot be controlled. But overall cost of a hospitalization, when you go to Nirmala Hospital or Aster Hospital, it's very different. Maybe Aster Hospital, people get the same care with 5 times extra cost. So it all depends on the purchase power. So the type of customers. So the same product of same quality, same quality surgery can be done in one small hospital, provided they have a good surgeon and the machines are good. So, I personally evaluated and found this, the same surgery with same precision, same outcome. It happened in a small hospital for around 60,000 rupees, but for that same, it cost 2.5 lakhs in Aster Hospital. Okay, that is in same place for the same treatment with same outcome. So that is the idea. Yeah, hope I answered.
Okay, sir, a question from the chat box. Shall I continue, sir?
Yeah, please.
How can we apply pharmacoeconomic analysis while recommending generic drugs?
Generic drugs?
Yes, sir.
Yeah, sure. So generic drugs are a way of saving money for the patient, and also, as resources are limited, whoever is paying, either patient or employer, because ESI is through employment, no healthcare is there, or the government is paying, government is subsidizing medicines. So whoever is paying, it's all resource for the people, and we don't want too much money to be wasted for medicines. So in the US, when I was there, automatically any prescription medicine, any brand is changed by the pharmacist to generic without asking the doctor, except some medicines like phenytoin, where brand to brand or brand to generic variation affects the treatment outcome, except that most of the medicines are substituted automatically by the pharmacist to save money for everyone. This is the same case here. It was not a trend of using generic medicines in UAE, but now in Abu Dhabi, they implemented it. Now pharmacists are entitled to change to generic medicines whenever possible, okay? Sometimes the patients will ask for it, but pharmacists will insist that this is as good as the brand, okay? And insurance companies like it, because they don't want to go bankrupt paying too much money unnecessary. Because when we can get the same good treatment outcome with a cheaper version of the drug, you should go for it. Yeah. Thank you. Next question.
Sir, you were in US, no?
Yeah.
Sir, like I always have a doubt that some friends in industry, they told that in order to export generic drugs to US, we have to maintain strict quality regulations. So the generic drugs in US, I believe they will be of almost equal quality as brand drugs.
Yeah, so you know, the US, UK, all these countries are called a highly regulated market. Highly regulated means, for example, MHRA in UK or US FDA, they have lots of resource, lots of people working. Because maybe in our regulatory department, when you see the number of people, number of labs, number of tests they can do, all these resources are less. So naturally what happens, the products which are sent to such countries, they do extensive tests. So, but these tests for quality cannot always assure that the generic is as good as the brand. Because technically, theoretically, we say that, but it is not the case in many situations, okay? For example, in my understanding, insulin is produced by many companies, but the other branded generics or pure generics of insulin by other companies, I don't think it is as good as Eli Lilly's insulin. Okay, some innovator companies, they have resources to make it in excellent quality, which the other companies, when they make it is good. It is as good as the original one, but not equal, not equal. Okay, so even if it is approved in the US, still for some products it will not be as equal, but it is not a big concern. You know, we have to make a trade-off. See, paracetamol is coming not as good quality as the a big multinational company brand. Still it works, still it is okay, you know. So maybe 5-star hotel tea and a tea from a small shop, compare, too much difference in cost, still tea is tea. So we have to, customers or the payer should take a choice or a informed decision when I can go for generic. I feel like most of the situations we can go for generic.
Okay.
But it is not a 100% answer. Yeah.
Yeah, like many MNCs, when our students are doing project work, when they assess the quality of generic products from some MNCs, they didn't get good results.
Yeah.
So according to what you have said, a poor man going for a generic drug may have to pay more indirect cost because of low efficiency of the drug. No, sir?
I agree. I agree. There is a good possibility for that, especially if it's all depending on type of medicines. Some medicines which are made in a complicated process. Usually the generic companies may not have that much sophistication in making the medicines. So, you know, I don't know if it is true. Another company, when they go for inspection, what I heard is that they put Eli Lilly's insulin in their product and send for testing because they whatever they do, they cannot make as good as Eli Lilly's insulin. So this is true for some drugs, but again, it is not a matter of concern for many other products, which can be made easily. Then even the generic will be as good as the original brand. Yeah.
Thank you.
Yeah.
Okay, thank you very much, sir, for clarifying the doubts.
Thank you. Thank you. So, shall I close the session?
Okay, sir, as we have reached the concluding part of today's session, I would like to thank Dr. Dixon Thomas for joining us. Once again, on behalf of Department of Pharmaceutics, Nirmala College of Pharmacy and entire team, we would like to convey our heartfelt gratitude to you, sir. Thank you very much, sir. And thank you all the participants for being a part of this session.
Thank you. It's a pleasure. I did work in Nirmala for some time, and
yes, sir,
it was
yes,
a great experience. So always very happy to talk to our friends and students. Yeah. Thank you then.
Sir, thank you, sir. Thank you.